A very good evening to all of you. And it's a great privilege to be a part of today's webinar as a moderator. I would really feel honored that on World TB Day, all of us pulmonologists from all over India and a very respected epidemiologist from South India has joined us to discuss a problem which is truly termed as the captain of all men's death or Raj Rogyam. World TB Day, celebrated on 24th March to commemorate Robert Koch's presentation of the tubercle bacilli in the Linden Research Society, is truly a day that we come together, we see the research which is being done, and we talk to each other that what more can we do to remove this deadly scourge which has affected our planet for millennia and millennia together. We as Indians have a double responsibility on our shoulders. Our target is of tuberculosis elimination by 2025, much ahead of the WHO target of 2030. We still have the very, very bad honor of carrying around 25% of all tuberculosis patients of the entire world. So, in order to update all of our fellow CCI colleagues, pulmonologists, we are now going ahead with a webinar which is having very star panelists, very learned panelists. I'm very happy to introduce our panelists, very honored rather. I would like to begin with honoring our Dr. Subhakar Kandi sir, who is professor at Nene Institute at Hyderabad. It is a big pleasure, sir, and a big honor to make you a part of this, have you a part of this webinar, sir. Thank you for joining.
Thank you, Ravi.
I would like to welcome Professor Dr. Animesh Jain, who is from KMC Mangalore. Sir is an eminent PSM personality, well known in his circles, and he is an avid researcher, very well known for his research. And off late, he is also going into politics of PSM nowadays. So
thank you.
We also have with us Associate Professor Dr. Amrut Kumar Mohapatra, who is joining all the way from Bhubaneswar. He is in the Institute of Medical Sciences, and I welcome you, sir, as a part of the panel today. We have our very own CCI co-founder and trustee, Dr. Narayana Pradeepa from Kasaragod. He has a very important role to play. He had a great role to play in COVID in his own district, and he is also a very important person of the National Tuberculosis Elimination Program of Kasaragod and Kerala. And I would like to welcome him. We pretty soon, Dr. Amita Nene ma'am, senior consultant from Bombay Hospital, Bombay, who is really not requiring any introduction. Ma'am will also be soon joining us as a part of this panel. So today we have an introduction of National Tuberculosis Elimination Program. What are the current tuberculosis strategies? Then we'll be having a very enthralling panel discussion. As you can see, we are spread all over the country. I forgot to introduce myself. I am Dr. Ravi Dosi. I am ex-CCI Secretary, and currently I am working as a consultant pulmonologist at Kokila Hospital in Indore. So without taking any of your precious time, I would request to start with the presentation on National Tuberculosis Elimination Program by Dr. Animesh Jain, sir.
So good evening, everyone. And today on the eve of World TB Day, we are here with CCI's webinar, and we are going to observe World TB Day. Let me just take you through some of these recent advances and also the genesis of the TB elimination program in India. So the evolution of National Tuberculosis Elimination Program, as it got christened in 2020, it got renamed. So actually, 1939, we in India had the foundation, or we laid the foundation of TB Association of India. And the goal was to develop standard methods for managing TB and also to develop model training institutions because we wanted to build capacity. And going further, 2 decades later, in partnership with the World Health Organization, that is WHO, Government of India actually went on to establish a very, very important institute that is called the National TB Institute in Bangalore. And going forward, National Tuberculosis Institute was thrust with the responsibility of actually coming out with the strategy to control TB in India. So in 1962, the National TB Control Program was launched, and it relied mainly on the domiciliary treatment, but it used the standard regimen at that time, which was available. Though the difference was this was a domiciliary treatment, not a hospital-based treatment, and it was using self-administered standard drug regimen. Then next 2 decades later, we launched in India the short course chemotherapy, which has been ongoing for a very long time now. So that was launched. The advantage was that short course chemotherapy increased the compliance, which was one of the major issues in the National Tuberculosis Control Program using the standard drug regimen. And in 1997, the revised National Tuberculosis Control Program started, which went on till 2019 in 2 phases, and it continued, and it actually achieved a lot of success as well. In 2005, actually, RNTCP was integrated and it became a part of National Health Mission itself. And very significant milestone, I would suggest or say, is in 2012, TB became a notifiable disease. So every practitioner who encounters or he sees a TB patient has to notify it. And that has really increased the number of cases reported, which I will show you in a couple of minutes from now to show the slide. And in 2020, with the strategic in strategic partnership as well as strategic review to end TB in India, we called the program again and renamed it as National TB Elimination Program. So these are the estimated incidence of all forms of tuberculosis in India as per the Global TB Report per lakh of population. If you see though the incidence shows that there has been a decrease over a period of time, however, it's not really at the pace or at the level that probably is anticipated or expected. So yes, we are reporting or we are having a lesser number of incidents of TB cases, and this includes all forms of TB cases. However, we need to have a little more aggressive approach probably, and then we would probably help to eliminate TB from India. This is the drug-sensitive TB notification. If you see again here, in 2019 and then 2020 and 2021, there has been a increase in the notification itself, and that has been very important because of the notifiable disease notification that came in. But what is more concerning here is the reported mortality among the different subgroups of drug-resistant TB patient is shown here, and these are all from the TB annual TB report. So if you see, only INH mono or drug-resistant TB in 2020 cohort was 5% death rate. However, when it comes to MDR or rifampicin resistant on shorter injectable regimen, the same goes to 11%. And oral longer regimen cohort of 2019 gave us a 14%, whereas extremely drug resistant had a very alarming rate of 21%. In other words, for every 5 patients, we had 1 mortality. And that is very, very alarming. We also started and resorted to another strategy, which is active case finding. Now, active case finding basically was going out and seeking and screening people and then trying to figure out how many TB cases we can find. And in 2021, 2.23 crores people were screened. That's the leftmost bar that you see. And then out of that, the people who was examined for sputum analysis was 0.8%, that is 17.5 lakhs. And then among them, we found that among those who were examined for sputum smear, and then we found that 4.2% were actually diagnosed with tuberculosis, which is considerable if you see for a country like India, which has a huge population. So there have been certain, I would say, positive things which have happened. And there has been highest political commitment towards TB Mukt Bharat Abhiyan by honorable governors. And no less than the president himself was chairing this meeting of all the governors and lieutenant governors. And they were actually asked to partner and also lead the campaign against TB elimination. So this was again told by the president to the governors, and the governors were supposed to carry it to the states. Again, if you see, second parliamentary meeting on TB was held in July 2021, 9th July 2021 to be precise. And here again, the Center for TB Division got the opportunity to organize this second round of sensitization for the Member of Parliaments. And this meeting was chaired by none other than the Vice President of India, Honorable Shri Venkaiah Naidu, sir. So again, it just shows that there is a lot of political commitment which is there, and that is a good sign. And then again, there was a conference, national conference on women winning against tuberculosis, which is again to bring in that gender sensitivity and gender highlight. So not to leave anyone behind, and especially when it comes to the women who are usually neglected. So here again, the Ministry of Health and Family Welfare collaborated with the Ministry of Women and Child Development jointly to organize this conference. And this was again the highlight. And on the right bottom, you see a TB module, which is also included in the Gram Pradhan induction material in Uttar Pradesh, which is again a very significant step. That means the leadership also should be aware, and they will be able to commit as well as also to contribute. So these are some of the good practices. So with that, I thought I will just sum up, and there are quite a few things, and of course we will discuss in the panel discussion that follows, moderated by Dr. Ravi Dosi and with my esteemed co-panelists. So I think with all these, though it's a challenge, but very aptly themed World TB Day 2023, yes, we can end TB. And I think if we all join together, we can definitely do so. Thank you.
Well, today, as part of our World TB Day program on CCI, we would also like to discuss on what are the current prescribed regimens for drug-sensitive and drug-resistant TB. What is the scientific logic behind these regimens, and how should we go about in special situations as far as treatment recommendations are concerned? The scientific basis of forming any tuberculosis treatment regimen is both on the basis of scientific as well as operational research. It has four major components. Ideally, the treatment has to be domiciliary treatment. It is a short course chemotherapy of roughly around 6 months. The treatment regimen should be very clear in its provisions, dosages, side effect monitoring, and ideally, it should be direct observation of treatment. Now, these basis of the bacteriological basis of the regimens are that there are existence of naturally occurring drug resistant mutants. So if there is a bigger cavity, there may be millions of bacilli in it, and that raises the probability that resistant mutant strains may also be present. If it is a smear negative or extrapulmonary, the bacillary load may be low, but still we need to be careful about the high bacterial population, and that too of resistant organisms. So we initially have an intensive phase. The objective of combining 4 drugs in the intensive phase is to achieve rapid killing of the actively multiplying bacillary population. This phase will eliminate naturally occurring drug-resistant mutations and further prevent emergence of drug-resistant mutants. Role of continuation phase is, by that time, most of the bacilli are eliminated, but if there is some amount of persisters present, which are responsible for relapse, the continuation phase of 3 drugs will take care of that too. The bacilli can be divided into extracellular rapidly multiplying on which our first line drugs like isoniazid, rifampicin, streptomycin, and ethambutol act very effectively. There can be extracellular intermittently multiplying on which rifampicin acts very particularly. There can be extracellular and acidic environment slowly multiplying bacilli on which pyrazinamide acts, and there may be dormant bacilli on which sadly no medicines act. Anti-tubercular drugs usually have these 3 actions, that is early bactericidal activity acting on group A, sterilizing activity of pyrazinamide acting on group C, and the ability to prevent emergence of drug resistance as per group A and B. The major first-line drugs, which are isoniazid, a potent drug exerting early bactericidal activity, preventing emergence of drug-resistant mutants, lower adverse effects. Rifampicin, again a potent bactericidal and sterilizing drug acting on semi-dormant bacilli. Pyrazinamide, is a bactericidal and sterilizing drug effective in eliminating the semi-dormant bacilli multiplying in an acidic environment. Ethambutol, which is an effective bacteriostatic drug, helpful in preventing emergence of resistance to other companion drugs. Streptomycin, which is a bactericidal drug known to reduce septicemia and toxicity. As we can see, efficacy-wise, the first-line drugs have the maximum efficacy amongst all the anti-tuberculars, be they the second-line ones, or the other newer generation anti-tuberculars. So, as far as possible, we always have to try that the patient is initiated on first-line drugs. Isoniazid, excellent early bactericidal, good sterilizing activity, helps in prevention of resistance. You have rifampicin, which is also having similar properties. Then you have streptomycin, which has a good bactericidal and emergence of resistance properties. You have pyrazinamide, which is good sterilizing activity. And you have ethambutol, which effectively helps in prevention of drug resistance. DOT strategy, or directly observed treatment strategy, has 5 major components or pillars: qualitative and administrative commitment, good quality diagnosis, uninterrupted supply of quality drugs, the direct observation of treatment whereby the health worker sees the patient swallowing the drug, and systemic monitoring and accountability, leading to good managerial management of the system. Drug sensitivity TB consists of 56 doses in IP and 112 doses in the continuation phase. The regimen in IP is that of 2-HRZE, and the treatment regimen in continuation phase is 4-HRE. This is for new and previously treated cases which are both isoniazid and rifampicin sensitive, or till the report is awaited. The patient is initially to be started on these medicines. What is available in the program are FDCs, fixed dose combinations. In adults, 4 FDC are given consisting of HRZD in IP and 3 FDC in CP. For pediatric patients, 3 HRZ and 2 FDC are given. Advantages are simplicity of treatment, increased patient acceptance because the pill burden is low. There are fewer tablets to swallow. It prevents concealed irregularity. There is increased health worker compliance also, easier drug management, and automatically, since it is an FDC, the use of monotherapy and thereby generation of drug resistance is limited. Now, the recommended doses in adults are isoniazid 5 mg per kg, rifampicin 10 mg per kg, pyrazinamide 25 mg per kg, ethambutol 15 mg per kg, and streptomycin 15 mg per kg. In children, the dosages are relatively a little higher. Isoniazid 10 mg per kg, rifampicin 15 mg per kg daily, pyrazinamide 35 mg per kg daily, ethambutol 20 mg per kg daily, and streptomycin 20 mg per kg daily. One another important aspect of the newer NTEP is the tubercular preventive therapy. It is given currently to the contacts. Isoniazid preventive therapy is used, and it should only be given after ruling out active TB and in patients who are aged 5 years or less and people living with HIV. The most commonly used drug in this is isoniazid, which is given for around 10 mg per kg body weight for a minimum period of 6 months. But we have to be careful that the tuberculin skin test should be less than 5 mm, should be positive, but the patient should not have any active disease. The patients who are receiving immunosuppressive therapy can be given this tuberculosis preventive therapy. All tuberculosis patients who are been diagnosed to have TB in pregnancy should receive means whose mothers have tuberculosis should receive isoniazid prophylaxis for 6 months. And asymptomatic close contacts of drug-resistant TB patients should be closely monitored for signs and symptoms of active TB. The main side effects of first-line anti-tubercular drugs are isoniazid, which causes peripheral neuropathy, skin rash, hepatitis, sleepiness. Rarely it causes psychosis. Rifampicin, which majorly causes GI side effects, hepatitis, generalized cutaneous reactions, and thrombocytopenic purpura. Pyrazinamide, which causes arthralgia, hepatitis, and GI side effects. Ethambutol, which causes retrobulbar neuritis. Streptomycin has a relatively larger side effect profile. It causes allergy, burning or tingling sensation, vertigo, nausea and vomiting, difficult or painful urination, blurred or double vision, severe hearing impairment, and fast or irregular heartbeat. It is very important that along with these potent first-line side effects, we also along with these potent first-line drugs, we also monitor the side effects very carefully. In pregnant women, we need to remember that streptomycin is ototoxic to the fetus and should not be used during pregnancy. So, other drugs can be used. Breastfeeding should not be stopped in pregnancy. The correct chemotherapy is the best way to prevent transmission of the TB to baby. And the baby should ideally be given 6 months of isoniazid therapy. Breastfeeding should always be encouraged, and cough hygiene should be explained to the mother along with supplementation of pyridoxine. In case of tuberculosis and contraceptive use, we need to understand that oral contraceptives are rapidly metabolized by rifampicin. So they should change the patient should change the mode of contraceptive usage. A stress should be given to barrier methods. IUDs and depomedroxyprogesterone may be used. In case of liver disease, we should be particularly careful if the SGPT is rising more than 3 times. We can use either only 2 hepatotoxic drugs like the 9-HRE regime. We can use 1 hepatotoxic drug like 2-SHR, 6 to 9 months of RZD, or 2-SHE regime, or we can use no hepatotoxic drugs, 18 to 24 SLE regime. In case of tuberculosis and renal diseases patients, we should estimate the creatinine clearance. We should see that streptomycin is particularly having an important dose modification or avoidance in renal disease. So is pyrazinamide and ethambutol. But as far as isoniazid and rifampicin are there, we can comfortably give tuberculosis patients with renal disease isoniazid and rifampicin in full doses. In seizure disorders, again, there is an interaction between isoniazid and rifampicin. High dose isoniazid may cause seizures, so we should use pyridoxine along with. The prophylactic dose suggested of isoniazid is 10 to 25 milligram per kg. For patients on cycloserine, it is 25 milligram of pyridoxine for every 250 milligram of cycloserine daily. Pyridoxine is an important component of tuberculosis in patients with seizure disorders. Now, coming to drug-resistant tuberculosis cases, NAT is compulsory. We need to understand whether the patient is isoniazid resistant, monoresistant, or multi-drug resistant. In case the patient is coming out to be rifampicin resistance, we go for a first and second line LPA and drug sensitivity by liquid culture. And even if the patient is not having resistance to rifampicin, we go in for a first line LPA, and subsequently, if resistance is detected to isoniazid, we go for second line LPA. The anti-tubercular drugs used for MDR regimen are divided into 3 categories. Group A, levofloxacin, moxifloxacin, bedaquiline, linezolid. Group B, clofazimine, cycloserine, or terazidone. And Group C. When formulating regimes, we try to take all 3 drugs from Group A, 1 or 2 from Group B, and 1 from Group C. The integrated drug TB resistant algorithm shows that if the patient is having rifampicin resistance and we have undergone the process of the microbiology and we come to a particular conclusion as to whether the patient is not resistant to any of those other drugs apart from rifampicin, we go in for the shorter MDR TB regimen. And if the patient is having particular resistance to any of the Group C drugs or Group A drugs, then we go for the all oral longer MDR TB regimen. And one very important thing is this is not a process which is evaluated only in beginning. There is a continuous process of evaluation at several intervals which goes on. So, which are the patients which will receive particular regimens? All oral isoniazid mono or poly regimen, isoniazid resistant TB cases with confirmed rifampicin resistance. Shorter MDR regime is given in all patients with rifampicin resistant who are pulmonary or extrapulmonary. Longer regimens are given in MDR patients who are pregnant, who are having extrapulmonary disease, disseminated meningeal or central nervous system TB, intolerance to any drug in the shorter MDR TB regime, or if there is resistance to fluoroquinolone, these second line drugs, INHA mutations, clofazimine, and pyrazinamide. Or if there is a history of use of more than 1 month dose of high dose moxifloxacin, kanamycin, ethionamide, or clofazimine. There are several newer drugs like bedaquiline or delaminate. The patients who are more than 6 years of age having MDR TB or rifampicin resistance, the bedaquiline or delamanate can be provided to the patient, provided they are more than 18 years of age. For children between 6 to 17 years of age, delamanate can be provided. Use has to be considered in adolescents and children only after approval of the DCGI. Non-pregnant females or females not on any birth control methods are eligible for bedaquiline, and the exclusion criteria is pregnancy and lactating mother, those having uncontrolled cardiac arrhythmias or having QTC prolongation, or who are having additional risk factors for tardive dyskinesia like heart failure, hypokalemia, and family history of long QT syndrome. This is the standard regime for initiating treatment in isoniazid. We give all oral 6 months of levofloxacin, rifampicin, ethambutol, and pyrazinamide. Whereas in the shorter MDR TB regimen comprises of an intensive phase of 4 to 6 months of high-dose moxifloxacin, kanamycin, ethionamide, clofazimine, pyrazinamide, high dose of isoniazid and ethambutol, and in the continuation phase we carry over to 5 months of high dose moxifloxacin, clofazimine, pyrazinamide, and combutol. There is also the all oral longer MDR TB regimen, which is given where the shorter MDR TB regimen is contraindicated, which comprises of 18 to 20 months of bedaquiline, 6 months of levofloxacin, linezolid, clofazimine, and cycloserine. There is also detection of non-tubercular mycobacteria. In that condition, the broad spectrum containing maximum non-tubercular mycobacteriums are Mycobacterium avium intracellular. So the regimen will be of rifampicin 450 to 600 milligram, ethambutol, clarithromycin 1 gram in split 2 doses, and injection amikacin. So now we would like to, after discussing these particular regimens, I would like to move on to the panel discussion and involve our panelists for our further discussion on several newer aspects of tuberculosis management. So, well, after these presentations by Dr. Animesh Jain sir and myself, we have highlighted what is actually set up in the National Tuberculosis Program currently for treating tuberculosis. So I would like to begin our panel discussion by asking respected Subhakar sir that, sir, I was talking about these regimens. Do you have any other newer TB regimens for drug-sensitive TB that you would like to share with us, sir? Is anything new coming up? Sir, you're muted.
Thank you, Ravi. At the outset, I thank the CCI for organizing this event on the World TB Day. I think you have given a bird's eye overview of various regimes currently available under National TB Elimination Program. This we are using ever since 1997. But of late, there are several trials were conducted because one of the drawbacks with the current regime is the drug-sensitive TB. The minimum duration is 6 months. So when the patient has to take for 6 months, most of the patients will not take the complete treatment. One of the reasons is that they lost for follow-up. Once the symptoms are decreased, they stop the treatment and ultimately leads to the drug resistance. So considering this, whether you can shorten the duration of treatment, these trials were conducted almost 10 years back by TRC Chennai, that is National Institute of Tuberculosis and Research Center. They have come out with a quinoline-based regimes, but unfortunately, they do not pick up because they have not studied the long-term follow-up after 2 years, whether the relapses are there or not. So that went to the cold storage. One of the recent trial, which was, I think, published recently in the New England Journal of Medicine, that is truncate TB trial. Their aim is to reduce the duration of the treatment of drug-sensitive TB, pulmonary TB. I'm telling about only pulmonary TB. They have not considered extrapulmonary TB, severe forms of TB, Other forms of TB they have not studied. And that they have classified into 5 arms. It is a randomized trial. They have conducted in almost 6-7 countries, multi-centric study. One in Thailand, one in Philippines, Singapore, London, and Indonesia, various countries. They have included more than 900 patients. There, what they have done is, now you have said there are 4 drugs in the intensive phase, 3 drugs in the CP, that is ethambutol, INH, rifampicin, and pyrazinamide. In the continuation phase, the 3 drugs, that is INH, ethambutol, and rifampicin. So by boosting the regime, because currently we have 4 drugs, by boosting the regime, can you reduce the duration of treatment? They have studied. What they have, for boosting what drugs they are used? They are using new drugs as well as repurposed drugs. New drugs, I think you already enlightened us, the bedaquiline and delaminate. The repurposed drug means those drugs are not originally for TB. They are used for some other indications, but they are also used in TB. That is called repurposed drugs. The repurposed drugs they are used is linezolid, clofazimine, and levofloxacin. And also they tried, normally you told the rifampicin dose is 10 milligrams per kg body weight. If you see the range, 8 to 12 milligrams is the kg body weight. Whether the high dose rifampicin can reduce the duration of the total duration of the drug-sensitive TB. So automatically they have converted these into 5 groups. One group, what they have given is the regime, what you have told us, that is 6 months National TB Elimination Program regime. And another group, they have given rifampicin 35 milligrams per kg body weight instead of 10 milligram per kg body, you have told. And not only that, they added linezolid also into that group, that is 600 milligrams, and have seen they followed these patients up to 2 years. In terms of the primary goal is in terms of the cure and also death, they also state. And the secondary goals are the drug tolerance, adherence, how many completed, what are the adverse effects, are the secondary goals. So in the arm 1, it is normal drug sensitive TB, what regime you have told. Arm 2, they have given rifampicin at higher dose and added linezolid also. In the arm 3, what they have added is, they have given again rifampicin high dose, but instead of linezolid, they have added clofazimine at the dose of 200 milligrams. So only change in the arm 3 is instead of linezolid, they added clofazimine in addition to all those 4 drugs. Mind you, all those 4 drugs, that means the patient is getting here 5 drugs. In the 5 drugs, one of the rifampicin is getting it a higher dose. And the arm 3, instead of rifampicin, they have given rifampicin. I think we are using this rifampicin for HIV, TB co-infections when we are giving, and also in the chemoprophylaxis. This rifampicin, they have given at the dose of 1200 milligrams instead of rifampicin, and they added levofloxacin 1000 milligrams and linezolid 600 milligrams. But so here, instead of rifampicin, and added 2 new drugs, that is levofloxacin and linezolid. In the bargain, they have removed ethambutol in this range. And the other arm is linezolid, they have given 600 milligrams, and bedaquiline 400 milligrams, as we give in the program, first daily 400 grams, after that 200 mg thrice weekly, as we give in for MDR TB. They have added these linezolid and bedaquiline. And they have proved that in this, they have removed the rifampicin. They have removed rifampicin. So altogether, it contains 5 drugs. That is INH, rifampicin, pyrazinamide, linezolid is 600 milligrams, and bedaquiline 400 milligrams. And they have seen over a period of 2 years, and they have proved that it is non-inferior to the regime what you have told us on the National TB Elimination Program. And of course, in a country like India, where we are not able to give bedaquiline for patients of MDR TB, is it a worthwhile giving a bedaquiline for a drug-sensitive TB? These are the things you have to consider. And a country where the quinine resistance is almost 18, in Mumbai, yesterday Vikas is telling that in Mumbai, the quinine resistance is 46%. Can you use these drugs? These are the things we have to dwell upon. And other than this, there are another 5 trials again for the drug-sensitive TB. There are at the phase 2 level, that is NC001, NC002, and NC003. In these, they have given protenomide, moxifloxacin, and pyrazinamide. In one of the group, NC, they give only 2 weeks they have tried, with 8 weeks and 2 weeks. And one more trial, which is a remedy trial, is they have given 2 arms. One, you have given EHR jet. Another group, they give a moxifloxacin, rifampicin, and pyrazinamide, ethambutol for 4 months. And they have proved that they are not non-inferior drugs. And one more trial is a STAND trial. This was given, they have tried with the proteonamide, moxifloxacin, and pyrazinamide for 2 months. And also the results are yet to come. These are all the trials which are there in addition to the National TB Elimination Program, where we are giving EHR jet for 4 months and another 2 months and another 4 months EHR. I think I have answered all the trials which are there at the drug-sensitive TB in addition to what we have.
Thank you, sir. Really, very elaboratively, you have told that much more is there in the horizon for tuberculosis, and very surprising to hear that a lot of second-line drugs are also now being tried out so that the duration can be reduced. Yeah. Well, the longer duration of tuberculosis often leads to people defaulting. So, Narayana sir, can you just comment that what do you feel the drug defaulting in TB is it still a problem?
Thank you, Dr. Ravi sir and Dr. Animesh Jain for a wonderful presentation, and it has given a very good mood to talk on TB on the eve of the World TB Day. And at the outset, I would thank CCI for giving me the opportunity. And it is my privilege to be with Dr. Amita, Nene, Dr. Subhakar, Kandi, who are the big names in TB in India. Thank you. Regarding defaulting, for example, do we take our own example? If we are getting one upper respiratory tract infection, lower respiratory tract infection, if you are, especially for doctors, if you are prescribed 5 days antibiotics, 1 or 2 doses will be missed, inevitably. So, unless otherwise it is monitored, 6 months, people definitely they are going to be defaulted. So, our program is very strict in this, and we are having like DOTS, direct observed treatment. Of course, that has come to a little backside after the COVID, because nobody is able to do the direct observed therapy, but still it is going on. Next is the home visits by the healthcare workers, like junior health visitors or our TB STS, TB treatment supervisors. If they visit the homes and they encourage, then the defaulting is very less. In our place, because we are doing a very regular home visits and very regular follow-ups, we do not have much of the defaulting. But definitely, if it is unsupervised treatment, there will be a defaulting.
Ravi, can I come in?
Yes, please, sir.
Yeah, I think with due regards to Narayana, Pradeepa, and you, so the default is now the patent of Nirav Modi and Vijay Mallya. So don't use the term default. The last for follow-up is the term which was, otherwise human rights people are objecting to use the term default. Now I already told this patent is Nirav Modi and Vijay Mallya.
Thank you for this very important. So like sir just told in his 1 minute correction to our practice, things are changing in tuberculosis. So Dr. Animesh Jain sir, is tuberculosis epidemiology really changing? Are we looking at different scenario now?
Answer is both yes and no. Many things have not changed. Some things have changed. So I hope I'm audible.
Very much, please.
Yes. So if you see many things what traditionally have been there, they are still there. Undernutrition, alcohol, all these are still continuing to be the risk factors which make people prone, as well as less amenable to the cure as well. So that has been there. But if you look at from the point of view of the trend, there has been a decreasing trend, both and the mortality has also been decreasing. So that's something which is some comfort we can say. Another thing which has been observed is, which was there and now we have seen it more prominently. There was a global burden of disease study which came out for 2 decades, and that looked at data up to 2019, and that showed us that in older age group, again, women are little less susceptible to mortality compared to the men. So men have a higher mortality compared to women. That has been there. And again, for 70, 75 plus age group, again, if you see, the susceptibility of males is much higher compared to women again. So these are some of the changes. But practically and personally speaking, I've also seen very young. In fact, last week I saw a TB patient who was about 24-year-old. Okay, somewhere from northeastern India. We had one patient admitted here, a construction laborer, and the kind of dwellings and also. I was just thinking of the implications. I'm sure that Dr. Narayana also comes across such cases because we are very close by across the border. So these things are there. But if you look at the overall statistics and the data, it suggests that there is a declining trend, and there is some comfort that way. So that's what I would like to say.
Well, Dr. Mohapatra, means in your part of the world, in Bhubaneswar, tuberculosis must be a problem for you. But what are the common differential diagnoses that you have in your practice of tuberculosis? Sir, you are muted. Sir.
Mostly non-resolving pneumonia we are getting, and the malignancy is still a little bit of confused with the actually tuberculosis. And definitely those who are bacillary, where you are not getting this challenge for proving microbiologically confirmed tuberculosis, we are actually getting a more difficult is like malignancy. Some of the one case we have detected that NTM case recently, most of the malignancy gets confused with the tuberculosis, and another non-resolving pneumonia that being still non-resolved but they are microbiologically not giving any CB9 negative or sputum microscopy bowel fluid also negative, but we are not getting results for them. So these are the definitely actually problematic for us is the malignancy and TB. They are sometimes very difficult actually for sampling and also microbiologically confirmation tuberculosis.
Sir, what about Mohapatra sir, tuberculosis and diabetes? Are you often seeing fungal also with them? What is your take on TB and diabetes?
Fungal infection still now not so. Actually, it might be actually some of the ICU patient, but in diabetes we are getting tuberculosis as a still more chances, and also this occurrence in atypical presentation is a TB is a most commonly upper lobe environment, but we are getting low lobe environment atypical presentation of actually TB in the uncontrolled diabetes patients.
Well, I would like to welcome Nene ma'am in the midst of our proceedings. Glad to see you, ma'am. And your music room awaits its.
I'm sorry for joining late. Actually, I got very badly stuck in the hospital. There was an emergency, so I'm sorry for joining late.
No, ma'am. You're perfectly.
In my car, and
you're perfectly well in time, ma'am. I saved you for the last, ma'am, because I'll be having a rapid fire of extrapulmonary tuberculosis with ma'am, which is something extra special that Krishna sir really wanted us to save it for the last. So yes, Subhakar sir, you were saying something.
Ravi, before Amita takes over, regarding the TB and diabetes, because we have done a big study and have published our data also. 15% of the diabetics will have tuberculosis. Okay. And when there is a coexisting diabetes, the relapse rates are very high, treatment failures are very high, and drug-to-drug interactions are very high. Similarly, if TB is not controlled, diabetes will not control. Diabetes is not controlled, TB is also. And that is the considering this, Government of India and the program has come out with a bidirectional screening. All diabetics should be screened for tuberculosis Similarly, all tuberculosis patients should be screened for diabetes.
Excellent. Can I just add something
Yeah,
more
please.
to what
Please,
Dr.
ma'am.
Subhakar said? Okay. Just information for everybody that there's a wonderful study, and there are like a lot of meta-analysis that, metformin, which is a drug which is used for diabetes, it has actually found to be having protective effect against TB, and therefore it has been said that whenever patients get diabetes, it's good to have them on metformin, because there was a lesser chance of people with diabetes to get TB who were on metformin, and also people who were on metformin and got TB, the chances of their sputum converting earlier negative and the radiological resolution was much better. So the thing is that it's always good to put these patients on metformin, because metformin has been found to be a TB immunomodulator, which does not really kill the MTB, but it improves the mechanisms by which MTB is killed, and therefore it prevents actually getting TB in patients who are diabetic. So in fact, a study is also going on in which 2 EHRZ 4 HRE is being given to diabetics versus 2 EHRZ 4 HRE plus metformin to diabetics, just to see if the response is better. And of course, we must remember, whenever a diabetic gets TB, whenever we start INH for the patient, pyridoxine must be given. We can't forget that.
Thank you, Amita, for bringing that important point of metformin role in management of tuberculosis. In fact, we are involved in one of the metformin trial in tuberculosis. Metformin has multiple roles. Now it is tried in polycystic ovary disease, and there's various trials are going other than the diabetes.
Yes. Thank you, sir. Yeah.
No, very important and relevant points raised by both our stalwarts here of the role of metformin, how diabetes, because India has been termed as diabetes capital. It has 25% of all TB all over the world. So this nexus of TB and diabetes is something which has to be looked into very, very particularly. But one thing which I really cannot forget is the COVID era. Narayana, after the COVID era, do you feel that tuberculosis has changed a bit? Are we seeing any change in the TB situation?
Sir, there is a dip in the diagnosis of tuberculosis during the COVID era, because probably because of the people who are not able to access the diagnostic facilities. And after that dip, we had a sharp increase in the 2021. Probably that missed cases where we would be able to pick up after that. That is one dip and then one sharp rises. That now it has become almost like stagnant. Not data is almost 2015 to 2020 and 20 to 23 every quarter on quarter and year on year data we have analyzed, and it is now it's almost similar. Number two data what we have observed is the drug sales in the private pharmacies of the anti-tubercular drugs. It has actually come down. That means there is patients are more into the government into the program rather than into the private KTTs. That is also we have observed. The second number two things. Number three things what we observed is the pediatric TB drugs, FD pediatric TB. That is actually on increasing. Probably that is maybe due to the increase in the tubercular preventive therapy as well. It does not mean that pediatric TB cases have increased. Maybe more of pediatric contacts have been traced and they are given the more TB preventive therapies. That is three things what we have observed. And in general, because in the post-viral, people are having more cough and their number of the TB diagnosis sputum examinations have also increased. But proportionately, that much cases have not increased. I have, shall I show that? I don't know it. I have that data, exact data of my district and my TB units, how it has actually performed. Quarter on quarter report and year on year report I have. Last 2-3 years I have complete data.
So, ma'am, Amita, ma'am, very relevant thing.
Ravi,
yes, sir.
Sorry because this COVID, because in the National Strategic Plan, I have written a paragraph on the impact of, because they asked me to, once they are ready with the National Strategic Plan, they asked me, it has come for my review. So it acted as a two-side edge, like a knife, COVID. So because of the lockdowns, because of the various deficiency in services, the incidence was not reported. Most of the cases are not reported. And those cases which were not reported during that period, they are now coming back. One important thing, in fact, we have given an operations research to one of the group here. Because of the COVID, everybody has used these masks. Where the usage of mask has an impact on the outcome of the TB, because in the South Zone, we have given this as one of the projectors. So the results are yet to come. So now new cases which were missing during the COVID, we are able to diagnose. And whether it is the epidemiology of this COVID has a positive effect of the COVID. And not only that, the government of India has come out with a bidirectional screening. All COVID patients were screened for TB and all TB patients were screened for COVID.
It's very relevant, sir. I fully appreciate and congratulate you on the fact on your paragraph in such an important document, sir. But I would like to bring in Nene, ma'am, and I would like to really hear from you, ma'am. How do we diagnose TB? I might sound childish, but I think it's a very relevant question.
Excellent question. I'm very, very happy that you've asked me this question.
You asked the right person.
Thank you, Dr. Kandi. No, so this is something very, very relevant and important. So before saying how to diagnose, I want to say how not to diagnose. So I want to say that, ESR is not diagnostic. A high ESR or raised CRP does not mean this is TB, because we know these are markers of inflammation. They are not specific. So the thing is that just because the ESR is raised or CRP is raised, we are not going to diagnose TB. Second thing is MAN2 test, or whether it's IGRA, the TB Gold test, or, even the blood serum IgG, IgM against TB. All these tests only tell you about TB infection. And MAN2 IGRA is important for starting TPT. But based on the result of MAN2 or IGRA, we are not going to diagnose active TB and put the patient on NICT. So basically, it's very, very important that we confirm diagnosis of TB by diagnosing and documenting MTB. So the thing is that if the TB is pulmonary, then of course we'll do a chest X-ray. If required, we'll do a CT chest, not necessarily required. But if you're suspecting TB and the X-ray comes normal, then you can do a CT chest. However, after we know that we are suspecting pulmonary TB, we want to bring out sputum. Patient can't bring out sputum, do sputum induction. Still sputum doesn't work out. Please do a bronchoscopy in BAL. But the thing is, no empirical treatment for TB in today's day and age, because we know that it's not only important to confirm TB, because like Dr. Animesh rightly said, Dr. Mohapatra rightly said, that very often malignancy and TB are getting wrongly diagnosed. So diagnosing TB upfront before starting empirical AKT is very important. And also it's very, very important to know upfront whether this is rifampicin resistant or rifampicin sensitive TB, because at least in Bombay where I work, we have 30% of primary TB as drug resistant TB, and therefore we should know what we are dealing with. So I would say that if it's, as I said, that if it's pulmonary TB, bring out sputum. Sputum is not coming to a bronchoscopy, and please do a gene expert. We in private practice we do gene expert ultra, but if you're in the government practice, please do CB-NAT. And the thing is that if the rifampicin resistance is not seen, then doing LPA first line is very, very important. In private, we do LPA first line and we also do LPA second line. A little later, if patient cannot tolerate one of the drugs, or if the patient gets ethambutol-induced optic toxicity, very often patients may get, then it's important to know upfront sensitivity or resistance to quinolones, because as Dr. Vikas told yesterday that we have 46% drug resistance to quinolones in Bombay at least. So basically the thing is that in today's day and age, we should make every effort to find out what is the resistance pattern upfront, and we always want to send it for TB culture midget so that we find out the sensitivity to everything. This is for pulmonary TB. So you do gene expert ultra in private, in government you do gene expert or you do CB-NAT. You do LPA first line, definitely if required LPA second line. If it is a resistant TB in private, even if it's sensitive, rifampicin sensitive, we still do both the LPAs, and TB culture has to be sent upfront. Now, if it's some other TB, if it's lymph node TB, if the patient is pus, please aspirate pus, send it for gene expert, do LPA, and even send it for TB culture. If the gene expert detects MTB, then even for extrapulmonary TB, we do LPA, and we've seen that it actually works out. So though the program does not really say it, we can always tell our patient that, look, this test will be helpful. If the result comes negative, no problem. But if it is positive, it tells you about the sensitivity, it's good. So lymph node, if there's no pus, then please do a USG-guided lymph node biopsy, or you can do excision biopsy. If it's fine TB, then aspirate pus, or you can do granulation tissue biopsy. You can even do bone biopsy. So basically what is important is whether pulmonary or extrapulmonary TB, we have to take out the sample before starting AKT. We have to confirm TB by either seeing AV smear coming positive or gene expert detecting MTB or TB midget showing culture positivity, and then only start treatment is very, very important. Then we won't make a mistake, and upfront drug susceptibility or drug resistance has to be ruled out. Thank you.
Thank you so much, ma'am. Really, very well elaborated in both the private and government setups. Like even the National Tuberculosis Elimination Program says that universal drug sensitivity for all is the norm now. There is no choice. Even if you want to make a diagnosis of clinically presumptive tuberculosis, you need a CBNet report attached along with all the evaluation that you have done. So, ma'am talked about a lot of things which are new world. But Narayana, I would like to ask you something which is very old world. Does BCG vaccination still stand? Does it have any meaning at all now?
Old is gold.
So then
basically, BCG vaccination is not for not for it prevents the severity of the disease. It prevents TB, meningitis. It prevents the severe miliary tuberculosis. It prevents the very severe forms of the tuberculosis. In that way, it has got role. We don't know exact mechanism how it works, but it has got some role in preventing the severity of the disease.
And Narayana, one very controversial topic which I know a lot of people would like to debate on is TPT. What is your take on TPT?
Yeah, whether you allow me to share my screen, I will, because I wanted to show screen data also.
It's up to you.
Yeah. India, my screen is visible?
No, not it's happening. Yeah.
Okay, programmatic management of latent TB infection among children and adolescents in Kerala is little different from the other parts of the India. So we have a change, some other regimens, because what we felt is in our place there is a declining growth and mortality rate is also very less, and high literacy rate and systematically organized primary health care systems and low HIV transmission. With this data, we felt like we will be able to give the good TB preventive therapy. And pediatric TB cases have also come down in Kerala. Average annual decline in pediatric TB notification is 7.5% from almost 10-year data we are having. And age-specific TB notification among less than 14 years is also around 1 per 1 lakh. And pediatric anti-TB drug sale had also steeper decline. And pharmaceuticals reported sale formulations declined from almost 90% compared to 2006 to 2019. Almost 20 years data we are having. And less than 1% of all presumptive pediatric TB samples were tested in the CBNet positive. So with this background, we felt we can go ahead with another regimen compared to the other parts of the country. So even in our Kerala TB elimination mission, we had sustainable development goals related TB, and we had a theme with the My TB Free Panchayat. And we have around 561 panchayats which had zero under 5-year TB. Then we had zero loss to follow-up panchayats, 688 panchayats. Then we had zero DRTB in 709 panchayats. So the mission was to like Akshaya Keralam, that means Akshaya Mukta, this thing. And here the basic idea was to prevent the infection, so that if we prevent the infection, we can prevent the disease. This was the idea of giving treatment prophylaxis. So we have divided into 3 to 5 years, 0 to 5 years, 5 to 15 years, and more than 15 years. And less than 5 years, I will stop sharing now. I will speak. Yeah. Less than 5 years, what we do is we do not do any testing. We do the contact tracing. And less than 5 years, we give 3 months rifampicin and INH. That is called as 3HR regimen. In other parts, maybe it is either 6H. 6 months they are giving INH treatment. So it is slightly different in Kerala. We are giving 3 HR for 3 HR. That means for 3 months, we are giving daily rifampicin and INH. Then 5 to 15 years, we do IGRA testing. It is available even in the peripheries. We do IGRA camps. We go to the private health centers with our sample collection team, and we do the contact tracing very well. And we take the samples and we do the IGRA testing. And 5 to 15 years, if IGRA is positive, we give again 3 HR daily. It is slightly different from the other parts. They give 6, either 6H or 3HP regimens. But here we give 5 to 15 years again, INH and rifampicin for 3 months in 5 to 15 age group. And above 15 years, if they are IGRA positive, of course, all the baseline is that for all the contacts, we do the active case finding. And if there is an active, we rule out that there is no active cases, we do the chest X-ray. And if it is IGRA positive, more than 15 years, we give 3 HP regimen. That means rifapentin and INH for 3 months. That is once in a week, not daily. Once in a week, we give INH and rifapentin. And what we have observed is when we have taken the data of the last 10 years, there is pockets of TB cases. So wherever there is, what we have done is we have identified the patients on the basis of their address, like PIN code 671121. 671551, like that we have identified the places, and we have observed that in the particular areas the TB pockets are there. So with the treatment prophylaxis, we presume that pockets can be eliminated, and we will be able to eliminate, give you a progression from the infection to the disease. This is what my personal feeling. I feel TPT is really working well, and it is going to be good.
Great. But, at times, frankly, when you were speaking, I thought that there is a lot of intelligence going on in the program over there. So are you using artificial intelligence also? Or is AI a part of NTEP now?
We have yet to, in the X-ray reading, we have started, sir, but not yet completely implemented. The project is going on.
Great. At times we have problem in, logging into the Nikshay app also, but you guys are generations ahead, means really hats off. So
can I add on the artificial intelligence?
Please, sir. Very well.
Yeah, we are using the artificial intelligence in chest X-ray reading, because one of the thing is in a peripheral health settings that primary health center doctors cannot interpret the chest X-ray. So that's why we have devised an artificial intelligence tool. Once you see enter this, the report will immediately go to him by WhatsApp. The report will go. Number one. One is artificial intelligence in chest X-ray. Number two is artificial intelligence is also we are trying in the interpretation of the LPA reports. Number two. Number three, the artificial intelligence is used by recording the cough. We are recording the cough. We can say whether it is a TB cough or COVID cough, the system will analyze. Now we are in the trial, Hyderabad, with IIT Hyderabad, we are doing this trial, and so it is giving a good results. And coming back to the Narayana's, Pradeep's long story to cut short the short story. To end TB, because we are asking to highlight on the end TB strategy. To end TB by 2025, treatment, curing, diagnosis is not enough. Prevention is one of the strategy. So prevention, we have two arms. One is BCG, another one is a chemoprophylaxis. You have highlighted, then now a lot of trials are going on BCG revaccination, like Revax trial, BRIC trial. They combined with chemoprophylaxis, and comparing this, because in the interest of time, I can't go into all those trials. And again, so if you don't use these preventive strategies, normally the annual incidence is coming down by 2%. If you want to end TB by 2025, the annual incidence should come from 2% to 19%. You know how much? So to achieve that, all these strategies should be used.
Right. But I really thanks, sir. Means, it's so heartening to see that we are moving ahead at a pace that is really required. And in order to eliminate TB, at times we have to work as hard and think as hard as the TB bacilli itself maybe. And so, but one thing which I gathered from Narayana's presentation on Kerala was the panchayat concept. So I feel local bodies and maybe professional associations like IMA, maybe Lions, Rotary, they all have a role. So Dr. Animesh sir, what do you say? Do role of professional associations in managing TB, is it there? Does it have any important role to play in the whole thing?
Definitely. And professional associations, I think, have a very, very big role to play. Take for this example, this CCI. I'll take this example that we are having this webinar. And if you see, in the last 1 hour or so, it's been so power-packed and so information-packed. And I think we have one of the best, gems all over the country who are sitting here. And it proves, I think we just got a thing that about, 925 plus logins or something. So that just shows, and that's really great. And coming aside from this, actually, even the associations, because what happens is all of us, whatever specialty we may be, we are part of some association, our own specialty. Like I am part of course, CCI, I'm a member, thanks to, Krishna sir and Narayana and others. So the other thing is, IMA, and I am also part of IAPSM and IPHA, that is Preventive and Social Medicine as well as Public Health Association. Now, we have a role because not just disseminating the information, but also participating, not just as provider of data, but also to our responsibility to see to it that the guidelines are followed, because otherwise, again, the drug resistance spreads. So that is very important. And from the professional association point of view, whether it is, you talk of API or IMA or CCI or any other organization for that matter, we bring people together, as well as people who are doing something progressive. Dr. Kandi sir, Dr. Subhakar sir just talked about AI, and I was really amazed because AI has a lot of potential. We already have heard of ChatGPT and Google is coming with its own Bard. So this has potential. I have seen it in the field of ophthalmology as well as in dermatology. Sir talked about, the AI-assisted diagnostic. It has a very, very big role to play. I'm not sure and certain whether it's already there. So I think professional associations can also try to look at, and trying to bring in people who can actually pilot it. And there is also a role, you happen to mention Lions and Rotary. I'm not sure whether it was by chance or, though they are not professional association from the point of view of professions that we are linking, but they have a big role. And in fact, that's why a few years back, Rotary, I've been a part of Rotary for a very long time. Recently, I've moved out, but more than a decade, and also a Rotaractor. Rotary has been roped in because the polio success story is one example. And Government of India wanted Rotary to partner so that, TB can actually be controlled and ended in India and eliminated from India. So I think there is a role, definitely a role, and we have a role to play, provided we do it responsibly. We also engage in disseminating information and also creating a platform where the professionals can engage and discuss, because sometimes, like Dr. Narayana shared some stories from his region, they can be replicated. Similarly, Dr. Subhakar talked about his experiences. So that's also very, very important. And of course, we have our own journals, which can help us in disseminating evidence-based approaches, because that's the need of the hour. We need evidence from our part of the world, not from elsewhere, but our part of the world, which works and which works in real situations. So that's what I would like to share. Thank you.
Thank you, Dr. Animesh sir. You really highlighted it that TB, if dealt with socially, means we need a holistic approach from every nook and corner of the society to tackle TB. Why? Because TB is such a difficult disease to manage at times. Amita ma'am, I would really like your help over here and like to understand, there are several special situations. I would like to really discuss with you a few special situations in which we really need help as how to manage these cases. I would like to begin with, suppose a guy comes up alcoholic with hepatitis. How do I manage his tuberculosis? What do I take care of?
Okay, fine. So the thing is that first of all, so basically this person is already having some liver problem before starting AKT, right?
Right.
Okay, fine. So the thing is that we first want to do his routine investigations. We want to do cirrhosis, his liver function test, PT-INR, and we want to know whether it is just AKT, whether it is just alcoholic hepatitis, or he's actually got chronic liver dysfunction like cirrhosis or not. So basically, that is very, very important. So if it's not chronic liver dysfunction, if it's just raised SGOT, SGPT, hepatitis because of a huge bout of alcohol or something, then what we are going to do is that we are going to wait till his SGOT, SGPT become normal. And we are basically, of course, because this is TB, we're going to upfront find out whether rifampicin resistance is seen or not. And from this, we'll find out from CBNAT. And after we know that rifampicin resistance is not seen, we are going to actually do LPA, and we're going to find out whether INH is sensitive or not. Because the thing is that over here, rifampicin and INH both are hepatotoxic. So if the patient is resistant to one of them, then we don't really need to give it at all. Having said that, at least in our practice, we also do LPA second line. So we assume that patient is rifampicin and INH, no resistance seen. So in this patient, in our practice, we will also do LPA second line, because we want to know the resistance to aminoglycosides and quinolones, because till the LFT becomes normal, we're going to be using aminoglycosides and quinolones. And if they are not working, then what's the big point we giving it? So assuming that we've done LPA first and second line and everything is working, okay? Or you don't have LPA second line, but still assuming it's working. So till the patient's LFT becomes normal, what we will prefer to give is levofloxacin to the patient. We'll prefer to give ethambutol, and we will give an aminoglycoside, which will be amikacin. Please note, and not streptomycin, because the thing is that initial guidelines used to say streptomycin, and we all have been, brought up on using streptomycin for AKT-induced hepatitis or streptomycin in a patient who's got hepatic dysfunction. So please note that with the new guidelines and the new way the drugs of AKT are now put in, streptomycin is not taken as a standard AKT. And we can use streptomycin only in special situations if we already know that the patient is sensitive to streptomycin from a good lab. Because in our country, initial streptomycin resistance is as high as 30%. That means out of 100 people who've never had streptomycin in the past, 30 of them will be intrinsically resistant to streptomycin. And please note, LPA tells you about kanamycin, amikacin, capreomycin. It does not tell you about streptomycin. So in today's day and age, we will use amikacin and we will not use streptomycin. So till the LFT becomes normal, we're going to use ethambutol, levofloxacin, and injectable amikacin. Once the LFT becomes normal, the first drug to add would be rifampicin. So we'll add rifampicin for this patient. On the 5th day, we'll check patient's SGOT, SGPT, bilirubin. Checking all three is important because OTPT may be normal, but if bilirubin goes more than 3, direct hyperbilirubinemia, then that is also taken as an indirect evidence of drug-induced hepatitis. So the thing is that on the 5th day, we'll do bilirubin, SGOT, SGPT. If the reports are fine, then the second drug to add is INH. And when we add INH, we'll take out amikacin, because now the patient is on ethambutol, levoflox, rifampicin, INH, 4 drugs. So amikacin is not required. On the 5th day, we will check the bilirubin, SGOT, SGPT again. And if that is normal, then we'll take back levofloxacin and we'll add pyrazinamide. If at all, the patient after adding pyrazinamide gets, on the 5th day again we check. And if the LFT gets deranged, then we will avoid using pyrazinamide. With INH, so basically the thing is that the last drug to be introduced is going to be the culprit, which we don't want to use in these people. This is how we're going to use it. As against that, if the patient had alcoholic cirrhosis, so, we all know that there are these Childs criteria based on that, based on the USG, based on the bilirubin, based on the INR, presence of ascites, we basically give scores. So if the score is 7 or less, then we can use 2 hepatotoxic drugs for these patients, INH, rifampicin. We will not use pyrazinamide. So it will be HRE and levofloxacin. If the patient score is 8, 9, 10, then we can use 1 hepatotoxic drug, which would be rifampicin. And with rifampicin, we'll give rifampicin, ethambutol, levofloxacin, and amikacin. And if the score is 11 and more, then we cannot use any hepatotoxic drugs. So no HRZ. Patient gets ethambutol, patient gets levofloxacin, patient gets amikacin. And with that, we can add linezolid. But please note the treatment duration will be 18 to 24 months over here and not less.
Well, so nice, ma'am. You cleared it. You made it crystal clear. Before I go on asking ma'am some more interesting scenarios, I would like to thank Narayana Pradeep. Narayana found time to participate in this panel. I believe he has an important function to attend. Thank you, Narayana, for being with us and sparing your time.
Thank you. I will join back. Yeah.
Yeah. So now going on with this very interesting discussion of tuberculosis in different scenarios, ma'am, I would even like to understand from you what do we do if we have a patient of chronic renal failure and we find tuberculosis in this patient, or suppose a person is on dialysis, how do we go about it?
Okay, excellent question. So the thing is that before we come to dialysis patient, whenever patient is abnormal creatinine, it's very, very important to find out what is the creatinine clearance of the patient. And this is very, very easy. Internet also has it. You just put down age of the patient, weight of the patient, the creatinine, etc., and you come to know the creatinine clearance. If the patient's creatinine clearance is more than 30, then actually we don't need to make any changes in the first line AKT. However, if the creatinine clearance is less than 30 ml per minute, in that case, INH and rifampicin doses don't need to be changed. So INH 5 mg per kg daily, rifampicin 10 mg per kg daily. Because the patient is CRF with INH, will be giving pyridoxine 40 milligrams definitely. Some people prefer to give 25 mg. I prefer to give 40 mg because it's easier to give. One tablet of 40 is available. What we need to know, this is very, very important for everybody, including us. Pyrazinamide and ethambutol, both these drugs are exclusively excreted by the kidney. So when patient's creatinine clearance is less than 30, if these are given in full doses every day, then the levels of these drugs will increase in the body and the patients will get all the side effects. Most importantly, ethambutol induce optic neuritis. And therefore, the dose has to be reduced. But please note, we are not going to give half dose every day. We are going to give full dose on alternate days. So INH rifampicin will be every day. Pyrazinamide and ethambutol will be full dose on alternate days. And this is very, very important. So we'll give ethambutol 15 to 20 milligrams per kg on alternate days, and on the same day we'll give pyrazinamide 25 to 30 mg per kg on alternate days. And this is very, very important because we all know to kill MTB, we require one-time peak level, and unlike pneumonia and other infections, we don't need continuous drug levels because we need one-time peak level. Therefore, we want to give full dose, and we don't want to have continuous peak levels, and therefore we're not going to give half the dose every day. So this is how we are going to be managing a patient. If the patient is undergoing dialysis, then the doses will be given after dialysis of pyrazinamide and ethambutol. INH rifampicin will be empty stomach every day.
Right. Thank you, ma'am. Really, liver and kidney disease and tuberculosis, sometimes it becomes very perplexing. But one thing, ma'am, I'm much more perplexed about is, what do I do with the steroids? Do I give steroids? There are indications, but really, it's a very, very controversial thing.
Okay, so this is a fantastic question because I really feel that role of steroids in TB, if we know when to correctly use, we can actually save lives of people. So we all know that steroids reduce immunity and people get TB because of reduced immunity. So we all have to think many times before using steroids, but there are certain critical recommendations. So if the patient has CNS TB, you have to upfront use steroids along with AKT. And if the patient has CNS TB, then based on the patient's GCS score and whether FND, any focal neurological deficit, so the patient's GCS is 15, and if there's no focal neurological deficit, then we have to give DEXA to the patient. The dose would be 0.3 mg per kg per day for the first week, 0.2 mg per kg per day for the second week, 0.1 mg per kg per day for the third week, preferably IV for the 3 weeks if possible. And then we give 3 mg per day for 1 week, then 2 mg per kg for the 5th week, and 1 mg per a day for the 6th week. This is how we give it. It is a 8-week longer duration starting with 0.5 mg per kg and 4 in the continuation if it's if the GCS is less than 15 or if there's focal neurological deficit present. If it's pericardial TB, then we have to use steroids upfront. And in fact, ATS guidelines does not recommend, but I'm very, very happy that our country guidelines have differed, and our country guidelines and our program is recommending steroids for pericardial TB because it is found to reduce mortality, morbidity, chance of constrictive pericarditis, chance of cardiac tamponade, etc. So we give 11-week course when there's pericardial TB. We prefer prednisolone, 60 milligrams a day for first 4 weeks, 30 milligrams a day for next 4 weeks, 15 milligrams a day for next 2 weeks, and 5 milligrams a day for the last 11th week. This is what we give. So CNS in pericardial TB we must give. If the patient has adrenal TB, then giving steroids actually becomes life-saving because you'll start rifampicin and the patient's adrenal, the cortisol levels will drop. So this is actually an emergency. So if there's adrenal TB, then please give steroids to the patient. If the patient gets hypersensory reaction to any AKT, which is like Steven Johnson or something, then giving steroids would be useful to these patients. In addition, if the patient has endobronchial TB, then certain types of endobronchial TB steroids are recommended. Like if it's a very caseous kind of a lesion, or if it's a tumorous lesion, or if it's a hyperemic lesion, then giving steroids in these patients is actually recommended. So these are some of the places where we'd like to give steroids to patients.
Thank you, ma'am. I think, please.
Very uncommonly, TB can present as ARDS. Patient has TB-related ARDS and respiratory failure. This is a time when starting steroids with AKT becomes life-saving. So these are absolute indications of using steroids. And plus minus, if the patient gets iris, then we can give steroids. If the patient has some ureteric involvement and a urologist wants to give, then we can give. Sometimes with bad eye involvement, we end up giving short course of steroids. But the first 6 ones, which I said, were quite mandatory. CNS TB, pericardial TB, adrenal suppression, or patient gets hypersensitive reaction, gets TB iris. These are the ones you want to definitely give.
Right. Really, thank you, ma'am. You really highlighted and specified the conditions where steroids can be, legally given in tuberculosis. So thanks a lot for that, ma'am. Dr. Mohapatra, one observation, like we in Madhya Pradesh have a very good government support in our tuberculosis management day by day. What is your experience in your part in Bhubaneswar? Are you involved, you're part of the government setup of tuberculosis?
I think we are not so that, because still if you are asking for CBNAT, actually we are getting the results after 7 or 8 days, even more than that days. So still I think the devices are coming, but manpower and these cartridges are still not enough to do the test very quick. Actually reports are delaying, and the decisions are also taking time for actually AKT. So yes, still not up to that mark. Our actually workouts are not up to that mark.
But I'm sure things are moving ahead, and with this, such an aggressive program, we are sure to have all these facilities very soon and giving rapid results. Subhakar sir, I would just like to you are having seen both sides of the world. You were head of the department in AP Chest, and now currently you are head of the department in Nene. So private and government TB management, sir, do you feel that is the way forward, या किसी एक कोई lead लेना पड़ेगी इसमें, sir?
Actually, TB elimination is only possible both government and private sectors work together. Not only that, only health department is also not enough to end TB. There are coordinated efforts with various others. Like, if you understand, the incidence of TB is due to various reasons, like poor ventilation, housing department, social department. I think you have told social disease. I think it reminds me the William Osler's quote: TB is a clinical disease with social malady. So how to address the social problem? Social welfare department. So many departments should be involved. So the private sector plays a vital role. 50% of our patients, the first point of contact is the private sector. If you see, and if you see, if there are 100 cases in the community, 50 are going to private sector. So without private sector involvement, you can't end TB. That is the reason now new strategies have come to involve the private sector by various means. You said whether the government is providing the CBNAT facility and all those things. Now the private sector is provided with all the facilities, because to avoid that gap, that they have employed an interface called private-public interface. So something will work as an interface between the government and the private sector. Previously, it is called JEET project. Now it was taken by another organization like Bhavya project. What they will do, suppose we are having a clinic. If any presumptive TB comes to you, if you want to get a CBNAT, they will come to your clinic and collect the sample and send it to the government sector. And because one of the goal of ending TB is zero catastrophic cost to the patients. So they do the free. And suppose if you have 100 patients on TB, they need medication. They can provide you at you. You can also, if you maintain all the statistics, maintain proper records, they can give you a DOT center to you also in the private sector. So if your number is very few, they can provide the drugs. And not only that, if you are a private doctor, if you diagnose a case, if you complete the treatment, they are giving 1,000 rupees. If it is MDR case, they are giving 2,500 rupees. So ultimately, by the end of the day, the private sector plays a vital role. Without the private sector's commitment, if you see, when the notification was started, the private sector notification is very, very, very minimal. Now the private sector notification has improved almost on par with the other, the public sector. If you see in state of Telangana, the Telangana is number 3 in the entire country in the implementation of the program, National TB Elimination Program, because of the public-private partnership works together. And you already raised some of the issues, professional organizations, other NGOs, everybody should be a part of ending TB. If you want to see a TB-free world, TB-free country, everyone should work towards that goal.
Thank you, sir. Thank you. I think you have beautifully advocated the role of private sector in tuberculosis. And of course, Narayana, like he beautifully highlighted the role of government in tuberculosis. And like Animesh Jain sir initially told that it's basically everything, and means the quote that you told, the social malady aspect of tuberculosis never goes away. So I'm really happy that we have had a very extreme holistic discussion on tuberculosis in today's panel. And before I leave, I would like to include our audience who has asked a few questions, which is open to the forum. I would begin by a question from Bindu Banumati from Kerala, that CNS tuberculosis, any treatment change in the regimen and duration of treatment? I think the most important change, Nene ma'am has already told, which apart from anti-tubercular, you need to include the different doses of Dexter at different times, depending on the GCS and focal neural deficit. Now, Pradeep Singh from Haryana asked that in a case of abdominal TB, how long can we give ATT if symptoms persist even after 6 months? Nene ma'am, would you like to comment on this, ma'am, please?
Yeah, so I would like to say one thing, that actually I always give 9 months of AKT. I'm in private sector, so my patients buy their medicines. If they are poor, I send them to government, and at the end of I personally because I always give 9 months, 2 months of EHRZ with continuation phase, 7 months HRE, because we had the BMC trials, Chennai 1960s, where the trials had shown that if you give 6 months of AKT, the relapse rate is 2%. And if you give 9 months of AKT, the relapse rate is 1%. And then with 12, 15, 18, it remains 1%. So for the government, it's absolutely correct. When they are looking at huge numbers, a difference of 1% in relapse doesn't make a difference. And therefore, when they make guidelines, they have to write about 6 months of treatment. But because I am in the private sector, and when the patient is paying for his own treatment, for me, if by taking treatment for 3 months extra, if my chance of relapse comes down by 1%, for me, it would mean huge. So having said this, at the end of 6 months, I always tell my patients, explain this. I document that I'm with their permission, I'm continuing treatment extra. So for every TB, whether it's pulmonary, whatever, I give at least 9 months of treatment. So I just feel that I would give 9 months of treatment for abdominal TB. And if the patient has not responded, if the patient's response has been slow, means the patient is definitely responding, but the response has been slow. And over here, if we don't have sensitivity to all the drugs, for example, rifampicin sensitivity is known, but for example, INID sensitivity was not known. We did not do LPA, and the midget culture did not come positive, or we could not do the midget sensitivity. In that case, if I don't know sensitivity to all the drugs, I will happily increase the duration of my treatment to 12 months. Because the thing is that we know INH drug resistance, even primary is 16%. So we can't really rule out this kind of resistance. So I think if the patient is not responding well, instead of 9 months, I would give treatment to 12 months. However, patient has to be responding. And at any given stage, I feel that the patient is not responding, or patient initially responded and now becoming worse, then I would like to investigate all over again. And if it was empirical AKT started, then I want to confirm TB. And if the rifampicin resistance or other drug resistance wasn't ruled out, then I want to rule out whether it was present or not. And most importantly, I want to confirm the compliance of the patient, whether the patient has been compliant or not. Because often we take treatment when we are unwell, and the minute we start feeling better, we start missing medicines. If the patient has been compliant also, then I would like to do therapeutic drug levels and make sure that the drug was nicely absorbed in this patient. Thank you.
Excellent.
Yeah, Ravi, I want to have one. I may have a different opinion. The government of India has given a clear-cut guidelines. The NTEP guidelines says the duration is 6 months. Suppose if you want, as a clinician, on case-to-case basis, if you want to extend the duration of the government has given a leverage to the treating doctor. So the minimum duration of treatment, optimum duration of treatment is 6 months. If you want to give another 3 months or another 6, 3 months, it is up to the treating doctor. Even the index TB guidelines also says the optimum duration of treatment is 6 months. So on a case-to-case basis, as Amita said, you can increase to another 3 months. The mere presence of symptoms is, so the symptoms is not an indicator that still there is an activity of disease.
I agree completely. And what is important is that if the patient is not responding very well, please think that probably compliance is affected or something like that. Basically, please investigate, do radiology if required. If there is some fluid, you can always aspirate again. But just make sure that the patient is taking the treatment correctly and the patient is still sensitive. That is very, very important.
One important point you highlighted, particularly in abdominal TB, the absorption may be less, the drugs, because the pathology is there at the level of absorption. So as you rightly said, in a case-to-case, you can do the therapeutic drug levels, monitor it, and the patient is responding to our.
Now, there are several questions. Yes, please, ma'am.
Just adding on to what Dr. Subhakar rightly said, HIV and diabetes are two conditions which are known to be associated with reduced drug absorption. And therefore, if the patient is HIV positive or is a diabetic or is having loose motions while AKT is going on, then please consider doing therapeutic drug levels. It's very important.
So actually, ma'am, you have actually answered our next question also. It was about HIV and tuberculosis, and particularly your answer has already answered that question from Dr. Meena Hangurani from Maharashtra. Now, there is another question from Bangalore. Dr. Prasanna Kumar asks, pre-XDR, is it the new kid in the block? And he also asks about pleural fluid IGRA. So any comments from my stalwarts, ma'am, sir, Subhakar, sir? Pre-XDR, would you like to comment on it, please?
Pre-XDR, I think it was clear. The definition is, in addition to MDR, if there is a quinoline resistance, you call it as a pre-XDR TB. So you have to give the regimes because already there is a levofloxacin resistance is there. You can't give a regime which contains levofloxacin. So on that case, may have to give the all oral long regime. For example, now BPAL and BPAL-M regime is there. Trial is going on. The BPAL-M regime is for XDR, because where there is no levofloxacin, if there is a pre-XDR, already the quinoline resistance is there, you can give the BPAL regime. Coming to the pleural fluid IGRA, don't ever do pleural fluid IGRA levels. It has no relevance. IGRA has only in the blood we do, and that too for establishing a latent TB. It won't tell whether the active TB is there or not.
Right. Thank you. Amazing. Not only do we have panelists from all four corners of India, we also have questions from every nook and corner of India. So it makes us feel very proud, and how the theme of World Tuberculosis Day is together we can all come and heal ourselves from this menace of tuberculosis. So I would just like a final quote from all my panelists on this World TB Day, going out to all pulmonologists, all the viewers of our particular discussion today, on your take on how we can contribute to ending this tuberculosis. I would like to begin with Amita Nene, ma'am. Please, ma'am, your final words, please.
I want to say that TB is our war against a germ which has really been a persistent pathogen. It was even found in Egyptian mummies. So we all have to get together, whether we are in private practice, whether we are in public practice, we have to hold hands together. We have to be a part of the program. Our government is really trying hard to eliminate TB. So let's make use of every possible new intervention and every possible new stuff which is coming to diagnose TB correctly, to diagnose drug resistance upfront. My genuine thing is that even if we are in private practice, when it comes to TB patient, let's not try to make money. I mean, let's be happy to see them free. Let's even give them money to get an investigation done. But TB-free India is the dream of our Prime Minister. And before that, it's been my dream ever since I was a student. Let's together work towards it. When it's a TB patient, let's not try to make money. Let's just treat them correctly. And let's make sure we can together end TB in our lifetime for sure.
Amazing. Really noble thought, ma'am. Amrut Mohapatra, sir, your concluding remarks on today's panel discussion, please. Muted, sir, you're muted.
The counseling part is very important. While you are dealing a TB patient and we are starting AKT, so brief about the disease severity, the toxicity of the drugs, and how to definitely complete the regimen, and regular follow-up visits is very important. because sometimes it is not actually particularly possible to this government people or anyone can trace the patient. Definitely, if you counsel the patient so that he will come regularly, so that the toxicity of the drugs, we are also facing still now the liver toxicity or hepatotoxic actually in our practice, as well as extrapulmonary TB are also challenging to diagnose and treat them, because in extrapulmonary TB there is no clear cut actually how to monitor them, whether patient is improving, not improving. These are very challenge actually. Pulmonary TB, you do chest X-ray, sputum examination, then you know the result. But in extrapulmonary TB, it is very difficult when to stop, how long will continue, if the patient is, and the follow-up is also very important. So always counsel the patient properly about the disease severity, how to come for follow-up, and to end the treatment, what is required for that patient, whether 6 months, 9 months, or 1 year. Actually, that is very important. Complete the drugs without the side effects of the drug and the toxicity.
Huge
Because
stress on
we have also seen patient losing their actually eyesight from the ethametal toxicity. We have seen patient actually dying from the liver toxicity. We have actually started ATT patient live in a hepatic failure, go to ICU, intubated, and death. So the toxicity is also very important of AKT, that clinicians should not. And the toxicity can be managed by the pulmonologist, not on the other specialists. Orthopedician can start ATT for the TB spine, but he can treat the actually the side effects of the ATT. So that's why if you are actually some patient is continuing actually anti-tubercle therapy, it should be monitored definitely by a pulmonologist or who are expert or trained for the treatment of tuberculosis. That part we are also missing, because there are some clinicians are starting ATT, but there is no monitoring about the toxicity of the drugs also.
Thank you. Sir, Subhakar sir, please, your concluding remarks on today's panel discussion, please, sir.
I think you have told us the TB bacillus was discovered as in today 141 years. When the Robert Koch discovered the TB bacillus, he has dreamt a TB-free world, but never thought that TB end. Already always control. Ever since the Prime Minister Modi has come with a vision, when he has advanced the vision from 2030 to 2025, everybody laughed. It is more, why already we have. So unless we have some goal, we can't work on that. I'm not saying that we'll end TB by 2025. At least one step was made towards, at least we have thought we can end TB. In that direction, the effort should go on. And ultimately, by the end of the day, to want to end TB, there are 4 things: find, treat, cure, prevent. These 4 pillars. You have to do these 4 pillars, and you must have an optimistic view that we can end TB. I think the World TB Day slogan is "We can end TB." So with that, we can definitely, not 2025. The steps are going towards the ending goal from the control. So ultimately, by the end of the day, the fight is not against the bacillus. The fight is against the human mind, which is seemingly unchanged. So we have to change our introspective and work towards the end.
Amazing, sir. Means from your discourse on AI to your last concluding comments, sir, you really means I am really proud of having you and listening to you, sir. Really, I feel proud, sir. Really, as a teacher of mine, thank you so much.
Whenever I speak about TB, I will speak from my heart.
Thank you, sir. Dear Animesh Jain, sir. Yeah, ma'am, please.
Sorry. Before you ask Dr. Animesh about his concluding remarks, there are 3-4 very interesting questions in the chat. Can we just take them? I was just
please, yeah.
So Dr. Sakshi has asked a very, first of all, she's commented, Dr. Sakshi from Telangana, Secunderabad. She has commented, awesome discussion. Thank you, Dr. Sakshi. Thank you very much. A very interesting question by Dr. Sakshi. She's asked, can you please throw some light on role of steroids in TB pleural effusion? So this is an excellent question. So basically the thing is that, whenever we diagnose TB pleural effusion, we don't have to upfront start steroids for these people, because the studies have shown that if we upfront give them steroids, then absorption of fluid is faster. However, if we are going to aspirate the fluid therapeutically and not give steroids, then at the end of treatment, the amount of residual pleural effusion, the X-ray improvement, restriction, etc. is the same. So we never give steroids upfront when we start AKT for pleural effusion. However, there are certain situations in which we could use steroids at our discretion. So these are not absolute indications, but these are like comfortable indications. When we get stuck, for example, we started AKT for the patient after confirming that this is pleural effusion because of TB and the patient is rifampicin resistant, rifampicin sensitive. We started AKT, and after 4 to 6 weeks, the fluid increased. We aspirated the patient again, the fluid, again after 2 weeks, the fluid increased. So repeatedly, despite giving AKT, if the fluid keeps on filling up because of the hypersensory reaction to the TB bacillus, then sometimes it gets frustrating for the patient. For TB, we don't really need to put an ICD or do a fluoridasis. So after 4 to 6 weeks of treatment, even if we go on for 8 to 12 weeks, and the fluid keeps on getting refilled, then giving a short course of steroids for about 4 weeks would be fine, which would help the quick absorption of the fluid. But of course, we do this only if the patient is refusing repeated aspirations. And while we are aspirating the patient again and again, we want to make sure there's no bacterial infection which is set in. So we want to send the fluid for bacterial culture sensitivity because it could be the reason why it's setting in. And at the same time, we want to also confirm the rifampicin resistance, whether it's there or not. Even if we've done it before, we want to confirm it. If you can do LPU on pleural fluid like we are doing in private, if you all can do it, please do that also and confirm compliance. But if the pleural fluid is repeatedly filling up in a sensitive patient of TB pleural effusion, then giving steroids for about 4 weeks should be fine.
Thank you, ma'am. Thank you. And really, ma'am, your academic interest and passion is something which is really, we need to imbibe it in ourselves also. Thank you, ma'am. Thank you for taking up that last question. Now, coming to Dr. Animesh Jain, sir, your concluding remarks, sir, please.
Thank you. First of all, thank you, CCI and all my co-panelists for having me here. It's been actually quite wonderful as well as enlightening for me as well. I think a lot of things have been said, and I wanted to say what Dr. Amrut Kumar Mohapatra already said, counseling, because that's very important. But we've also actually emphasized the role of, that social disease. This TB has a lot of those social factors. So I would like to highlight two important things. One is that we have to create a society where there is a lot of awareness and people know about this, so that, you'll be surprised. I have also come across, not very often, but I have come across, there is some stigma still. So that is something which I think we need to dispel. That is one thing which we need to dispel. So that will happen with, collaboration from multiple sides, including some of the NGOs and the media. That is one thing. And of course, educating people. The second thing is, I always, coming from, and you introduced me by saying research, I always feel that we need to have research. Because research and innovation is the need of the hour, whether it's TB or anything else, but more so for TB, because this has been there for a long, long time. And if we really want to win a war or win over this TB, I think we need to come out with things which are innovative, which are evidence-based, and from our part of the world, because then only we can implement things, and then only we can go ahead and see to it that it is actually working in our part. And from here, many of the things will actually be taken to the other parts of the world as well. So this is what my message would be. Let's try and keep our eyes and ears open. And another last thing would be, whatever practitioners we may be, whatever specialties we may be, I think we should always, have this suspicion of TB if at all we feel some kind of, symptoms which are there, because irrespective of whatever practitioner we may be, we should be a basic doctors, and we have to keep that on. And if needed, we can always refer to our colleagues in the specialty. They can manage, but it has to come from all the specialties. Then only it's going to really work out, because sometimes patients don't come directly to a pulmonologist or a physician, but they might have gone for some other specialty, and from there they could have been referred. So that's very important as well. So that's all my take-home message. Thank you.
Thank you. So together we will defeat this menace of tuberculosis. हमारा देश जीतेगा, मानवता जीतेगी, ये विश्व जीतेगा और टीबी हारेगा. With these words, I would like to end today's panel discussion. Thanks CCI, thanks all of my respected panelists, and thanks to the wonderful audience who has logged in huge numbers. And let's celebrate this World TB, not celebrate, let's mark this World TB Day with a determination and passion that really we offer sympathy and our shoulder to the TB patient, and we offer courage to the TB patient's family, and together we come and defeat tuberculosis. Thank you. Good night.
Ravi, just a minute. Thank you so much for the excellent moderation. I think you were just fantastic. Wonderful job. Thank you so much for keeping all of us so involved in it. And really a pleasure being a co-panelist with my dear friend Dr. Kandi, with Dr. Animesh, with Dr. Mohapatra, and of course Dr. Pradeepa Narayan, who had to leave. And thank you, team CCI, Dr. Krishna, Dr. Vijay Kumar, Dr. Ravi once again, Dr. Atri for this fantastic conceptualization of TB webinar on the eve of World TB. Thank you so much.